Now gain, we have to adjust overall gain and of course our TGC curve. And we also want to avoid false echoes within any kind of a fluid structure, so that if we see free fluid or fluid in an area and it has some echoes, how do we know that those echoes are true or actually false echoes? Here's, for example, a patient with a collapsed urinary bladder. We're scanning transvaginally, and there is some free fluid in the pelvis. There's some bowel loops, but we see some echoes. Are those real? Is this a hemoperitoneum, or is this pus in the pelvis? Or is it just our gain setting? Well, we compare with a known anechoic area. The bladder has clean urine, and this has echoes. Therefore, these are real, and this was hemoperitoneum. Whenever we have a fluid structure, we should do a gain analysis, a low gain, high gain analysis. There was a pelvic mass here. It looked like it was completely anechoic, looked like clear, like the bladder. But when we slowly crank up the gain, we see that this mass fills in before the urinary bladder. So we know that these echoes are real, and we have to explain them. This was a chronic fluid structure that had developed some crystalline material. Okay, so we have our technique correct. We know our orientation. Now we start scanning, and before we go looking around for uterus and ovaries, we should take a quick peek at the urinary bladder. So to do this, we have to angle the probe anteriorly, and that sometimes gives us that opportunity to find a very anterior mass. Like in this patient, this was the uterus here, and we were trying to find the bladder, and we found that instead there was a very large mass there. Here's another patient. We tried to angle for the bladder, and there was an endometrioma plastered to the anterior surface of this uterus. So we can recognize anterior masses much better, not miss them. The other thing is we can find urinary bladder masses or find some other condition. In this patient, who was in severe pain, young woman in severe pain, it looked like she had a dilated bladder. With the transvaginal probe, as we scanned around, we tried to make sure that we saw the bladder, and we found the little corner. It's in the left upper corner of our picture, and this mass, which happened to be this same mass, we realized that this was a mass, an ovarian mass, that had found its way anterior to the uterus and was not the bladder at all. The bladder was actually small and collapsed, and only because we looked for it were we able to see that there was truly a large mass in this patient, and it happened to be a torsion. We don't want to mistake a cystic mass for the bladder. This was an adnexal torsion. There was the infarcted ovary, there was the dilated tube, and it's separate from the collapsed bladder. Now, when we take a peek at that urinary bladder, which we often just ignore during our scan, we may find something that's very significant. This was a 30-year-old patient. She was having her first trimester ultrasound, and we just took a little peek and we saw an irregularity in the bladder. Took a little closer view, this was her pregnant uterus, took a closer view and found a mass. Converted to a full bladder view and found an irregularly shaped mass. This was a transitional cell carcinoma in a first trimester patient. This was a 80-year-old lady. She's postmenopausal, and she came for postmenopausal bleeding evaluation. But after we evaluated her uterus and her ovaries, we found that everything was fine. The endometrium was nice and thin. And we spotted in her bladder a couple irregular masses. Further investigation revealed that these were solid masses, and this woman had 2 transitional cell cancers in her bladder. It actually happened that this was not postmenopausal bleeding. This was actually hematuria. She complained that when she wiped herself with some tissue, she saw blood, and she right away thought it was vaginal spotting. But in fact, this was urine that had blood, hematuria. So now that we've quickly analyzed the position of the bladder and the appearance of the bladder, we now move to the cervix. You should look at the cervix separately and directly. You want to be perpendicular to the uterus. You want to leave the rest of the endometrium and the fundus and the corpus out of your picture, 90 degrees to your area of interest. This helps you to quickly see is there any kind of mass inside the cervix. In cases of ectopics, the cervical ectopic could be there. Deep cul-de-sac is imaged. That could be a place where a mass is hiding. This endocervical line is your guide into the endometrial cavity. This helps you with uterine positions. So we want a nice view of the cervix. This is not adequate. Such a view of the cervix where the cervix is half cut off here is not adequate. We want to be 90 degrees. Here we are a little better, but not good enough. We go completely 90 degrees and we see that there is a mass in the cervix. It's actually bulging out. The mass was here and we were only imaging a part of it because we were not seeing the complete fundus and we were not seeing the complete cervix. So we should start with the transvaginal view of the cervix. And in this case, Doppler showed that there was a large vascular pedicle to this, and this alerted the surgeon that there could be hemorrhage during removal of this mass. Here's another case where a pitfall did occur. A patient came in overnight bleeding, and a quick scan showed that it was an intrauterine pregnancy. And everybody was happy that there was an intrauterine pregnancy. However, the patient continued to bleed and bled profusely, which resulted in emergently going to the OR and sustaining a hysterectomy. What had happened in retrospect was there was a cervical ectopic. Well, the cervix was never looked at. The fact that we saw the intrauterine pregnancy was made everybody feel that this was just an IUP, and nobody really took the time to investigate the cervix, which had another pregnancy in it, a much more dangerous pregnancy, which resulted in massive hemorrhage to this patient. This was in the days before IR, the days before we were using methotrexate, but this poor patient lost her uterus because nobody spotted that there was an abnormal pregnancy in the cervix as well. It gives us a quick look at the deep cul-de-sac where we could see echogenic fluid, in this case hemoperitoneum. We could see even peritoneal implants in these patients who have histories of malignancies. The cervix is a guide to the rest of the endometrial cavity. Here, when we follow the endocervical line, it leads us straight into the cavity, and we know this is an intrauterine pregnancy. We would never mistake this for being anywhere else. Here, it guides us straight in. We get the orientation. We can measure the endometrium, which is a proper measurement. Here was a patient, a postmenopausal woman with bleeding. She has a small uterus, and we saw that there was some echogenic material in here. We wanted a good measurement of her endometrial thickness. So we use the cervix as a guide to lead us straight in. We have a longitudinal position of orientation. We know this is the longitudinal uterus, and now we can measure the endometrium correctly, which was way too thick, and this was endometrial carcinoma.